Good evening, my dear colleagues. Today is our monthly Oculoplastic Service meeting of Cairo University Pediatric Ophthalmology and Strabismus Unit. I am glad today to have with me my dear colleagues sharing interesting case presentations. Our first case is a unique one because it is not purely oculoplastic. It is more of a neuro-ophthalmology case, but I think it's nice to get out of our scope a bit and know about cases that may have signs and symptoms that are a little bit confusing. It may present as an oculoplastic case, but it is actually more of a complicated case, and this is one of these cases. So I would like to welcome my dear colleague, our fellow from the police hospital, Colonel Dr Islam Metwally, who is going to present the first case with the title of Not Our Case to It's All Ours.
Good evening, dear professors and colleagues. Thanks for this opportunity, and I hope today's presentation will be at your satisfaction. I'm Islam Metwally. I'm Deputy Chief of Ophthalmology Department at Police Hospital at Aguza. Okay, as Dr. Rania said today now, it's a bit complicated case between oculoplasty and neuro-ophthalmology. That's why my title was From Not Our Case to All Ours. Our case is a male patient, 12 years old. He has post-brainstem neoplasm neurosurgical removal 3 weeks ago. His only chief complaint was red right eye 1 week ago, as it's presented here, and even it's not that red. Family history and consanguinity are unrelated. On examination of this boy, he was uncorrected vision was 6/6/30 and 6/6 at the left eye. There were lag of thalamus bilateral, but more right side, bilateral bulging eyes. Was it proptosis? We will examine. There was no pain, no extensive red eye. I repeat, no pain, even no lacrimation. By examination, as we can see here, it was right corneal ulcer at the lower nasal cornea, was overrolled edges, and positive fluorescein stain. Left cornea also show diffuse punctate keratitis. The corneal sensation was tested and bilaterally was markedly reduced. How this will influence our treatment strategy, we will discuss it later. By more examination, pupils were rounded, regular, reactive, bilateral. Anterior chamber, anterior segment was clear, no hypopyon. There were upbeat nystagmus. We will see it later in the video demonstrated. Extraocular muscles motility, there was proven bilateral horizontal gaze palsy. He can't move his eyes neither right or left. His fundus was clear fundus picture with good macular reflex and normal retinal blood vessels. No disc edema and cup dusk ratio was 0.1 OU. I will return back about the bulging of the eyes. By measurements didn't prove no proptosis and were found to be pseudoproptosis, as there were no true forward displacement of the eyeballs. In underweight individuals, especially those who are significantly malnourished, this happens due to loss of periorbital fats, makes the eyes more prominent, and the sunken cheeks and temples due to generalized fat loss in the face that make bony structures more visible and enhance illusion of proptosis. So it was only pseudoproptosis. About the bilateral horizontal gas palsy, eyes As I said, I can't move right or left, only up and down. This is mostly affected by damage to paramedian pontine reticular formation, PPRF, or medial longitudinal fasciculus, impairing the connection between the third and sixth nerve for the lateral and medial recti muscle. Let us watch this simple video. Okay, this is just a close-up for the corneal ulcer, if anyone can see it. Okay, we will ask him now to try to move all gazes. He couldn't move it. No left, just up, down. As you see, there is a rile. That's why he is malnourished. He has been on rile for 3 weeks. So let us talk about neurotrophic keratopathy. Neurotrophic keratopathy is damage to the sensory innervation, causes a reduction in the lacrimation reflex and the mitosis of epithelial cells, with a subsequent deficiency in epithelial repair. The exposed stroma becomes vulnerable to the enzymatic degradation and melting, and eventually it could be perforated. There is a bit murky classification just for guidance for the treatment. We have stage 1 punctate keratitis, like the left eye, persistent epithelial defects, and corneal ulcer. This is another way for treatment based on the classification before we suggested by Mackey. A variety of options was based on disease severity. As we said, stage 1, the punctate keratitis, avoid preservatives. You have to use a lot of artificial tears. Stage 2, if it is persistent, you have to do tarsorrhaphy, or you might do a conjunctival flap. At stage 3, you might use a contact lens or amniotic membrane transplantation. On corneal perforation, I'm sure you will use a conjunctival flap, amniotic membrane, or even keratoplasty. This is only a table down in there. You will see as topicals. We can use artificial tears, corticosteroids, but very minimal, covered by antibiotics. We have to use antibiotics and avoid preservatives, as we said. In office procedures, we can use contact lenses if needed, punctal occlusion, and non-surgical eyelid closure, or amniotic membrane and tissue adhesives. The surgical interventions, as it said, tarsorrhaphy, conjunctival flap, or corneal transplant. So what would be your step in management? Fluorescein staining was done and demonstrates a reduction in the tear time and the formation of dry geographical points and corneal epithelial defects. So it was not just an ulcer. There is also dry eye, and there was no lacrimation. So management was of choice was lubricant eye drops every 1 hour and prophylactic antibiotics every other hour, alternatively, and follow up after 2 days. In neurotrophic keratopathy, you have to do a very close follow-up. Don't make it by weeks, it's by days. On follow-up after 2 days, unfortunately, lateral tarsorrhaphy was ordered to be done temporarily to protect the eyes, plus adding diluted insulin drops also to the previous treatment. He was not healed that good, and we were afraid of more deterioration of the ulcer. I would like to speak a little bit about insulin drops. Actually, I learned it in Qasr Ain University, and it has a great results, as we will see later. It's about 10 units over a 10 milli lubricant bottle. You must use only Act Rapid, and we use it every 6 hours. We must avoid insulin analogs or long-acting formulations. Dilute 1 milli of 100 international unit milli insulin with 9 milli of sterile lubricant to achieve a final concentration of 1 international unit per milliliter. Store prepared drops in a refrigerator. Continue until complete epithelial healing, typically from 20 to 60 days, depending on ulcer size. So you can use it freely even to 60 days. This was after 2 days. Healing was very good and started to heal after just 1 week, sorry. And this was only after 3 weeks, and the vision was uncorrected, returned to 612. It was 630, 36, sorry. As we can see, healing was almost perfect. But yet, there was no lacrimation and still no sensation of the cornea. This is only a video to demonstrate still movement of the eye and the corneal epithelial healing. Am I going fast or is it okay?
No, it's okay. Thank you.
Okay. Now let's talk about horizontal gas palsy, and I know it's a little bit sometimes neuro-ophthalmology a little bit harsh, but I will be specific and just to the point. So just to remember, this is a classification where the cranial nerves of the brainstem, as we see, I high-marked the nerves of interest. Optic nerve and third and fourth are from midbrain, and as we see, trochlear fourth nerve are in the junction between midbrain and bones. The trigeminal nerve and abducens and facial nerves are all on bones. This is okay. This is another one to demonstrate where exactly is the nuclei. So, as we said, oculomotor and trochlear are in midbrain. Sixth nerve are in bones, and the trigeminal are all the way from midbrain to bones and sorry, let me get this back. Sorry, I have to mention something here important. Our main interest in this case are the medial longitudinal fasciculus. As we see here, they are in the bones and also the paramedian pontine reticular formation. And here is the nucleus of the sixth nerve. Okay. Okay. Why is medial longitudinal fasciculus that important? It is the horizontal gas pathways. Okay, as we say, the third and nucleus and sixth nucleus are conjugated in the medial longitudinal fasciculus. Sorry. And to be noticed, medial longitudinal fasciculus are very close, as you can see, to the aqueduct and the fourth ventricle. Parapontine reticular formation are away, and that will be discussed later. So notice they are close to each other and close to the fourth ventricle and aqueduct. So in a normal pathway, the abducens nucleus have two types of neurons. The motor neurons from abducens nerve to supply the lateral rectus and interneurons to connect between both eyes It's called interneurons in the medial longitudinal fasciculus. This is the interneurons, and here you can see for the leftward gaze and rightward gaze normal pathway, and it's located mainly in the bones. Okay, we have some just differential diagnosis we could notice again. Why it's not intranuclear ophthalmoplegia? Number one, mostly intranuclear ophthalmoplegia, we refer it as INO, mostly will be unilateral medial longitudinal fasciculus will be affected. So it's either the leftward or the rightward. It's very difficult to be bilateral and to be in the both gazes, right and left. Plus, it's mainly caused by vascular more than tumors and compression. And as we can see here, the conversions are in a defect. And this is the main differential diagnosis between it and the horizontal gaze palsy. So vergence signals were found in midbrain. So what does this mean? The third nucleus is intact. Third nucleus is intact. So it's not something wrong in the third nucleus. It's not something wrong in the medial rectus. The main problem here are in the bones, in the medial longitudinal fasciculus and bilateral medial longitudinal fasciculus. Which diagnosis do you think is most likely? What was his tumor? It was ependymoma in the fourth ventricle. These tumors can form of any ventricles in the brain, but most are in the fourth ventricle, exactly where we were discussing at the medial longitudinal fasciculus were at the bones and affecting cerebellum and brainstem. So our interest here is very important because it's the ependymomas are the third most common brain tumors in children. Before the pathology, I thought it was astrocytoma. Mostly what's my interest in this? It's for prognosis. Is it infiltrating? It's not infiltrating. So when the pathology came and it was ependymoma, sorry, this was good because we suggested it is a compressive lesion rather than infiltrating and destructive. Tumor causes blockage of cerebral spinal fluid flow with symptoms of hydrocephalus needing ventriculoperitoneal shunt. Survival rate of childhood luckily is 50 to 70%. As I said before pathology, I thought it was astrocytoma. Both are very common in children, and as we said, astrocytoma even is the second brain tumor in children. So observed in pediatric population, we have to be aware of it. Ependymomas are reported 4 to 6 times more common in children than adults. So these two are we have to notice in children, in pediatric population specifically. Astrocytomas usually have a better prognosis and are often benign with a favorable outcome following surgery, particularly in children. Why might I give hope for better prognosis? The lesion are, as I said, it was compressive. So it's not, we were afraid it's iatrogenic. We were afraid because of the surgery made it like iatrogenic, maybe medial fasciculus was injured by surgery, but when I asked a neurosurgeon, they said, no, it's because surgery is always from dorsal, not ventral side, and away from most cranial nerves. I have a preoperative MRI. This is a coronal section of the preoperative. As we can see, there is a space-occupying lesion in the fourth ventricle, and mainly in the midbrain, still not that compressive, but as if you can see the bones, It's totally blocked by the tumor. The tumor were huge. This is the sagittal section. If we see the second row, we can see it how it is compressing the cerebellum, how it is compressing the bones, the totally blocking the CSF and causing hydrocephalus. Lastly, this is an axial cut space. It's in midbrain. No, not that there's no compression in midbrain, and compression was all in the bones. There is a FLAIR MRI, positive active signal showing obstructive CSF flow also. Same here. Okay. First, they did a CT scan post-operative. It was marvelous. We can get two things from the CT scan. The ventricles were reduced and becoming almost normal. There was no more like CSF and intracranial tension increase. And we can see that here is a shunt done to this child. The pathology report, it was, as I said, it was a huge mass. It was 2.5 by 2.5 centimeters, which is huge. And it was pielocystic astrocytoma, and fortunately, it was grade 1. Post-operative MRI, there's a fine residuals for follow-up. It was minimal. It's only like 1.5 by 1 centimeters. But it's almost the lesion were enhanced, and as we can see, the CSF duct is patent now. You can see in the second row. Okay. Sorry if I was long, but let me say the last key points learning. When I said it was not our case and then all ours, don't take the blame for others. So when the parents came with the child, he was only interested in the surgery. And once I told him about the corneal ulcer, he started to forget about the surgery, forget about the main problem, and he was only focused on his eye, and any mismanagement or any problems, he will tell the doctor, and he will forget about the neuro-ophthalmology following up, and he will concentrate on the ophthalmology. He will think that this is now, he is all right, he did his surgery, he will need nothing, and he will concentrate with you. So always just remember, remind the parents, this is about the surgery, this is about the surgery, this is about the surgery. Neuroimaging is not just a report. Uh, Thanks so much for CAPS and Aborish, all doctors, Professor, Dr. Special, Dr. Ghada. She
معلش الصوت راح يا إسلام، ممكن تفتح المايك بتاعك؟
sorry, okay. Again, أنا آسف, where was I? Sorry.
You said the cuts were helpful, the MRI cuts were helpful.
I used even not that easy to read it before. Thanks so much for the neuro imaging lectures. I have been with you. It was very useful. And every time I needed help in any later neuro imaging or even imaging of the orbit, I can use a friendly neuroradiology doctor like Dr. Michael. Lastly, it's important to say, as ophthalmologist, We are the masters of cranial nerves. يعني don't rely only on neurology doctor. You are the master of the cranial nerves. Please check all 6 nerves of them. It's half of the 6 of the 12 nerves in your hands. Just do it in neurological repair in order. Best corrected visual acuity, pupil, all extraocular muscle gazes. Versions is very important. Corneal sensation, lid closure, then dilate, then look at the fundus. Don't just rush into fundus examination and forget you are the master. Many information you can get only from the neurology from the ophthalmologists. Thank you so much, and I hope I was meeting your satisfaction.
Thank you very much, Dr. Islam, for this interesting case. It's a little bit out of our scope in oculoplastic surgery, but I think we needed to know that not all proptosis means it is something related to orbital tumors, but there are many other conditions, and you have to take examination seriously, as you just mentioned. Examine the cranial nerves, examine the corneal sensation. The tarsography that was done here was a temporary tarsography, as you note from the bolsters used, because they expected the healing would be rapid with using the drops, and it would no longer be needed. Sometimes we need a permanent tarsography if we have like a permanent 7th nerve palsy following also intracranial surgery. But this was not the case here. Thank you very much.
Thank you so much.
Any questions from the audience? Okay, if you can stop sharing, please, Dr. Islam, to allow
okay, thank you so much.
To allow Dr. Menna, Dr. Menna Abu Hamed. She's also a fellow in CUPS, and she's going to give us another case titled "Not a Classic Case of Panophthalmitis."
Good evening, my dear professors and colleagues. I'd like to present you a case for a case of panophthalmitis, but it's not a classic case of panophthalmitis. It's a female years-old patient. She's the first sibling of positive consanguineous marriage, and she came to oculoplastic clinic with right eye proptosis, and she has a gangrenous ecchymotic patch all over her body. The ophthalmological examination, there is no abnormality detected in OS of the patient. OD, there is conjunctival edema with ecchymosis, which is more in the inferior part of the conjunctiva. No extraocular muscle movement. There is a frozen tense globe with positive retropulsion test. Cornea show large epithelial defect, which were 8 by 6 millimeter. Pupil reaction can be assessed with fundus, can be assessed at this eye as well. The general examination and investigation done for this patient. The condition started 20 days ago before with high-grade fever, post-immunization, post 6 months immunization. The fever was responding partially to the antipyretic, but the patient hospitalized when she developed the gangrenous patches all over her body, over the upper limbs and her lower limb as well. No previous history of trauma or spontaneous bleeding from any orifice of her body or even subcutaneously. And there were no conscious level deterioration, no lymph node enlargement, no organomegaly, and and the patient has a cleft lip and a cleft palate. The full labs had been done for the patient with echocardiography, Doppler, CT brain with contrast, and coagulation profile as well has been done. And here is the CT brain and the orbit with contrast had done for the patient. We show the right eye proptosis with the thickening of the extraocular muscle of the right eye. But there is normal appearance of post-cavernous sinuses. The patient has normal echocardiography with normal Doppler of the upper and lower limb, except from the area which was necrotic, which can be assisted. The D-dimer of the patient was elevated to 8 milligram per liter. C-reactive protein increased from 20 to 200 milligram per liter at the time of admission. The coagulation profile show protein S deficiency to 41.6%. And the patient received blood transfusion on admission as her hemoglobin dropped from 9.8 to 6.8. At this point, the patient diagnosed as orbital cellulitis, and the patient management was triple antibiotic systemic therapy adjusted according to the pediatric dose, with oral anti-inflammatory has been prescribed. Topical Vigamox cysteine gel Vigamox and cysteine gel was described every 2 hours, and ciprocin eye ointment at the bedtime, with a close follow-up every 24 hours was recommended. But that was the patient picture 5 days after the previous management. And at this point, the ocular ultrasound was requested. And here is the ocular ultrasound, show a picture of suggestive of right panophthalmitis with opaque lens, with incomplete BVD, with exudative retinal detachment. The ophthalmological diagnosis and management. The case diagnosed clinically and with ultrasound as the case of severe orbital cellulitis with panophthalmitis. The case management with intravitreal injection of 45 antibiotics, vancomycin with photium with diflucan preparations. And the patient also take 45 antimicrobial eye drops every 2 hours. And this is the patient photo 3 days after this management. What is the cause of our case panophthalmitis? The patient diagnosed with clinically, systemically from the pediatric department as disseminated intravascular coagulopathy due to, probably due to vitamin S deficiency that usually cause sepsis with gangrenous patches all over the body. The DIC is a complex condition where abnormal blood clotting can lead to both excessive clotting and bleeding. So our panophthalmitis case can be related to DIC. Yes, here is a case of his case recorded of 26 years old female with DIC, which is diagnosed firstly with central retinal artery occlusion, ocular ecchymosis, then ocular edema, then ended by optic atrophy in spite of intervention and the treatment. How can panophthalmitis related to DIC? The microthrombosis and the bleeding caused by DIC can cause both excessive clotting and bleeding. So the clotting or ischemia can cause necrosis, then secondary infection, then may cause panophthalmitis. The DIC can cause anterior segment ischemia, particularly if there is systemic inflammatory response from the DIC all over the body. With which also there is a scenario that orbital vein thrombosis can happen, then the stasis and the infection can occur. Also, there is a relation between panophthalmitis and DIC, usually seen as a sepsis. Even bacteremia or candidemia can cause endogenous panophthalmitis. And vice versa, there is inflammatory response in panophthalmitis, which can trigger the coagulation cascade and can cause DIC. So our case may be a case of endogenous endophthalmitis, which ended by panophthalmitis, yes, but it's a rare condition which occur only in 2 to 8% of all cases of endophthalmitis. Even the endogenous panophthalmitis also can be linked to the systemic condition with immunocompromised or hospitalized patient. So our case show improvement of eye proptosis over systemic and intravitreal with topical antibiotics. Also, she started in the pediatric department anticoagulant, start Clexane, once diagnosed as DIC. We recommend to give the patient corticosteroid under antibiotic coverage as well, with a close follow-up for the patient systemically and ophthalmologically. So our case may be a case of ischemia, which causes stasis and then secondary infection, or can be a case of septicemia and the endogenous panophthalmitis. So our take-home message, not every endophthalmitis case caused by infection. Anterior segment ischemia could be a main cause of panophthalmitis, and to follow our patient general condition is very important. And thank you.
Thank you very much, dear Menna, for this presentation. I think this patient was fortunate to start the anticoagulant therapy early, because this might be the key to resolve
Yes,
the condition, in addition to using
she
the
improved in
traditional
general condition even as well.
Okay. Anterior segment ischemia is really a devastating condition, and it might happen due to different reasons. But this is a case happening due to orbital stasis and disrupted coagulation causing this DIC and this complicated panophthalmitis. Are there any questions from the audience? Okay, thank you. So now we can proceed with our final presentation, case presentation. Hemangioma, lymphangioma, and their management. Cases presented by our resident, Dr. Heba Mabrouk.
Good evening, dear professors and my dear colleagues.
In progress. In progress. In progress. Progress.
Heba, are you speaking?
نعم يا دكتور.
Are you talking or not yet? Because
Not yet.
we can't see anything yet.
The presentation is in sharing.
Okay. Yes, now we can see it. You can start sharing the.
Okay.
So can you press on the resume slideshow?
كده البرزنتيشن.
Yes, we can see the slides, but you did not press the slideshow.
Okay. I am trying, but there is something wrong.
خلاص, you can if you can move it from the original original presentation, and you can move the slides manually if you couldn't make the slideshow. Or do you want me to share it for you?
Yeah. I am trying to sharing again.
The same problem?
هو كده كمان هو كده شيرنج من عندي يا دكتور، هو ظاهر لحضرتك؟
No, it's not appearing here. طيب, let me try to share it from my computer. I have your presentation. Can you stop sharing?
اوكي يا دكتور.
Okay, can you see it now?
اوكي I see.
خلاص, you can start. I will pass the slides.
I am Heba Mabrouk, ophthalmology resident at Rania Hospital. I am going to present two cases. The first case about hemangioma and the second case about orbital hemangioma. The first case, hemangioma case, this patient, 3 months old female, presented to us complaining from swelling on the right side of her face, medically and surgically free. The swelling since birth. On examination, the lesion was raised lesion, reddish in color on the right side of the face, including the right upper lid, causing mechanical ptosis. Was increased in size with crying and screaming, blanching with pressure. On examination of the anterior segment was normal and fundus examination was normal. No proptosis from crying or screaming. Our clinical diagnosis was capillary hemangioma. The capillary hemangioma, it's the most common tumor of the orbit and pre-orbital area in childhood. It is composed of anastomosing small vascular channels without encapsulation. It's organized over growth of mature tissue normally present in the involved area. The lesion usually appear in the first few months of life. Approximately 30% of cases are present at birth. The superficial lesion is bright red in color, called strawberry nephus. The deeper tumor appear dark blue or purple in color. The larger tumor may enlarge and change in color to deep blue during crying or screaming. The course of capillary hemangioma characterized by rapid growth in the first 3 to 6 months after diagnosis, but followed by spontaneous resolution. 30% of lesion resolved by the age of 3 years, and about 75% by the age of 7 years. The differential diagnosis of capillary hemangioma, both stem, but the lesions are typically flatter, darker in color, and don't branch with pressure على عكس الهيمانجيوما. Not a change in size like capillary hemangioma. The second lesion, biogenic granuloma, but this lesion, rapidly growing vascular lesion, mimic hemangioma, but developed after trauma or inflammation, has friable surface, is deep untouched. The third is lymphangioma, a vascular malformation following lymphatic vessels. Lymphangioma will be discussed in the next case. The imaging of capillary hemangioma, usually it's performed to rule out a more extensive orbital disease. It appears hypodense, with dense than surrounding tissue before a contrast administration, but shows significant enhancement after intravenous contrast administration. It has a lobulated appearance, irregular shape, and not absolute region. This is done for our patient to exclude the intraorbital extension. The management option of hemangioma, as discussed before, that the typical course of capillary hemangioma characterized by initial enlargement followed by spontaneous regression, but there is indication for treatment include risk of amblyopia, severe cosmetic defect, infection, or necrosis. The first option is medical treatment. الميديكال treatment, the first option is beta blockers. The most commonly agent is systemic propranolol, causing remarkable regression in the patient with eyelid capillary hemangioma, because it causing vasoconstriction, decreased expression of VEGF, which are presented during the course of capillary hemangioma. The dose of systemic propranolol is 1 milligram per kilogram per day. Propranolol solution on the first day, because propranolol causing hypoglycemia and bradycardia. The vital sign will be checked in the second day. If the vital sign is still stable, the dose will be doubled on the following day. The maintenance dose is 1 to 2 milligram per kilogram per day, divided into doses. The patient should be fed 2 to 3 hours after administration of propranolol to avoid hypoglycemia. Then the course will be the dose of systemic propranolol will be twice a week for 2 months, and then monthly for 20 months. If no further improvement occurring during the follow-up, propranolol will be tapered over 2 to 3 weeks. Also, there is topical preparation, including timolol, are equally effective with excellent results and no systemic side effects. The second option is intralesional injection of steroids into a continuous oral pre-septal lesion, usually effective in early lesion. Lesion usually occur within 2 weeks after injection, but if necessary, second and third injection will be given after 2 months. The complications that may occur after the injection, like central retinal artery occlusion, it's advisable to not to inject deeply in the orbit. Other complications include skin depigmentation and necrosis, fat atrophy, and systemic side effect of steroid, like adrenal suppression. Systemic steroids also an option to be administered daily over several weeks, may be used, particularly in case of large orbital component or rapid onset of action is required. The third option is surgical resection of residual lesion after the course of medical treatment, systemic propranolol, or in case of failed medical treatment from the first, or in case of huge tennis ball hemangioma. Early surgical resection of large eyelid hemangioma following 3 days of high dose of parenteral corticosteroid administration to avoid amblyopia and other complication of hemangioma. Another option is the embolization by the team of interventional radiology by delivering embolic agent like liquid glue or particles directly into the bleeding vessels of the hemangioma to block blood flow and potentially reduce the tumor. This technique is typically used for a large hemangioma or before surgery to reduce the bleeding or as primary treatment. The treatment protocols used for our patient, systemic propranolol started at the age of 6 months. Then this picture after 6 months of systemic propranolol only. Then after 1 month, 1 year, propranolol followed by surgical debulking for cosmetic effect. The second case, the lymphangioma case. This is female patient, 1.5 months, presented with bilateral microphthalmia and left cystic swelling increasing in size. The swelling is transverse. On examination, the lesion was left soft bluish mass causing proptosis and ptosis. The swelling is progressive upward and prolapse with prolapsing conjunctiva. The right eye was microphthalmia. The MRI required and ultrasound. The MRI bilateral intraorbital lymphangioma, aplastic right group, hypoplastic left group. The ultrasound of the right eye showing evidence of infiltrating intraorbital cystic lesion suggestive of Hemangioma with rudimentary group. An ultrasound of the left eye, evidence of infiltrating intraorbital multiple cystic lesion, displaying the blue upper band suggestive of Lymphangioma with hypoplastic group. The Lymphangioma are multicystic localized malformations that involve lymphatic and vascular system, most commonly occurring in the head and neck region. Diagnosis based on clinical presentation and imaging. CT scan demonstrates cyst-like masses with varying degree of enhancement along with cystose fluid, has no definitive border. On MRI, orbital lymphangioma are generally characterized with presence of internal septation within the lesion. This lesion can be located in various orbital components and may infiltrate surrounding tissue. Glossognomic findings include multiple cysts with air fluid. The option of lymphangioma management is observation in case of no vision, sleeping symptoms, or physical disfigurement. The second option is therapy. Multiple types of agents are injected under ultrasound guidance into the base of the lesion, causing scar formation and reduction of size, like polyomitis. The third option is surgical debulking and or excision, but there is high risk of recurrence. The management of this case, this patient is being for sclerotherapy injection under the guidance of interventional radiology. The sclerotherapy, it's a minimally invasive procedure for lesion with a macrocystic component. This technique is preferred over surgery for deeper lesion or as alternative when a surgery not easy or not visible. Procedure technique. The first is imaging performed under ultrasound or CT guidance to ensure accurate needle placement and injection. Then aspiration of cystic fluid from the cyst can help to inject the dye after that and help to confirm the diagnosis through cytology. Then injection of dye to localize the lesion, and then an injection of polymycin into the lesion. This is the pictures of another case before and after the sclerotherapy injection. And finally, thank you.
Thank you, Dr. Heba, for these two interesting cases that actually represent one of the common orbital masses in pediatric age group, the capillary hemangioma and the lymphangioma. Of course, the lymphangioma, in our opinion, is more complicated because there is no medical treatment like the case of hemangioma, as you just mentioned. I would like to take the opportunity of having Dr. Sameh with us to ask him his experience with propranolol treatment in treatment of capillary hemangioma. Do you have any tips and tricks in this management?
دكتور رانيا كده أنا دخلت متأخر كنت فاكر الميعاد 10 مش 9 اتلخبطت. Actually, we have been using propranolol for hemangioma for quite a long time now. We shifted from 15 steroids to 15 for oral propranolol use since like 15 years. You have to contact your fellow pediatrician to start the treatment. According to the presentation we just heard, the dose is 1 to 2 milligram per kg. Would be started gradually, starting from 0.16 milligram per kg, and then increased gradually over 2 weeks. Actually, some advice is to follow the patient in the first few weeks of propranolol use. If it's gonna work, you will find rapid or at least significant improvement in the first few weeks. Another tip is to not to be afraid to augment with steroid injection, even if you are using propranolol systemic treatment. You can still always boost your treatment with some steroid injection if you need a more rapid response. And finally, don't ignore the surgical option. especially in cases with large tumors and or tumor count that can cause amblyopia for the child. Thank you for the presentation again.
Thank you, Dr. Sema. So, in your opinion, how long would you give the chance for propranolol management alone?
Actually, there is no definite time. As long as there is no risk of amblyopia and the child is improving, I would give. I have patients that have been using propranolol for months. Like some of them are using it for 8 months or 9 months or so. I think this is the longest patient I have.
So you still get good results even after a year of propranolol use, for example? Because I have a couple of patients that I had to keep giving them propranolol for up to 2 years. What is the longest period you tried?
Actually, it's around 1 year.
Yeah.
Since if the child is improving, there is
Yeah,
no,
if the child is actually very young when it, what is the earliest age you use propranolol for?
I don't think there is a definite age limit to use propranolol.
But I'm quite afraid to use it before 6 months because of this incidence of sometimes going into severe hypoglycemia. We usually start it at the age of 6 months. And if the child is improving in propranolol, we sometimes wait until the age of 2 years or 2.5 years. I have some patients who keep improving up to 2 years of use of propranolol. But if they're not responding from the start, I think we should resort to other possible treatment.
Yes, that's important. And that's usually evident in the first few weeks of treatment.
Yes. But actually, if the patient does not respond to propranolol, do you think he will respond to steroid injection?
Yes, not responding to propranolol does not mean that it will not respond to steroid injection. Some tumors.
So it is, you're not giving the injection to get a rapid response, but rather you're trying a different mechanism of action.
Yes.
Because sometimes I have patients who are not responding to both, and in this case, I resort immediately to surgical resection.
Of course, then you have no option.
Yeah. Embolization is actually a new thing, and it's quite interesting because it aims at blocking the feeder vessel. And again, we have to resort to our fellow interventional radiologists in order to attain this new modality of treatment. But it's giving quite good results. Okay, so that's all for today. I thank you again for all of you who attended our meeting. We will have our summer break and we will resume our monthly CUPS Oculoplastic Service meeting, inshallah, on the second Sunday of October. We're having a 3 months vacation. So it's going to be the Sunday, the 12th of October, inshallah. Thank you very much once more and have a nice holiday. Thank you.
Thank you so much.
Thank you.
Thank you, Doctor.